Welcome all to the today's session. Today's talk is about surgical smoke. What are the risks? This is a talk article, and this talk is from surgical skills module, and it's important from the MCQ or SBA point of view. So we begin with our quote: "Master MRCOG with concept-oriented clarity." At the most, one SBA will be asked from this particular topic. So please listen. So what is the source and exposure? So it is generated by the energy-based surgical instruments like diathermy, laser, ultrasonic devices, etc. All operating theater staff and patients are exposed to the surgical smoke. What are the components of surgical smoke? See, the main component is the water vapor. It is more than 95% is a water vapor. Okay, so there are three components basically: water vapor, chemicals, and biological matter. So water vapor is the main constituent and it acts as a carrier for particles. Chemicals such as toxic gases and chemical compounds, they are potentially irritant and carcinogenic. And biological matter, that is like bacteria, viruses, etc. There is a risk of transmission of the infection also. So the health risk will include respiratory tract symptoms, irritation of the eyes, nose, throat, coughing, headache, etc. And there is a possible infection risk also due to the presence of bacteria and viral particles. And carcinogenic risk is associated with the exposure to toxic chemicals which are present in the smoke. Okay. So operating staff face multiple occupational hazards, and the various occupational hazards are like there is a musculoskeletal strain, sharp injury, then body fluid exposure, psychological stress, etc. And surgical smoke is less recognized, but one of the common occupational risk. It is generated intraoperatively during use of thermal energy devices, and inhalation will lead to the respiratory tract infection, infective transmission, and possible carcinogenic risk. Okay, so mitigation requires education, training, and policy development. Sources of surgical smoke, airborne surgical byproducts, they are also called as plum, vapor, or bioaerosols. Okay, so it's actually surgical byproduct. This smoke is a surgical byproduct. Okay, and it's also called as plum, vapor, or bioaerosols. It is formed by thermal destruction of human tissue via energy-based instruments and generated by the electrosurgical devices like monopolar or bipolar device, laser devices, ultrasonic scalpels, and plasma energy devices. Okay. So what exactly the mechanism is? See, when we use the cutting mode, see this cutting mode uses continuous waveform, and that will lead to the heating of the cell up to 100 degree, and that will lead to the cell wall explosion, and that will cause the water vapor release. Okay, so there is a explosion of the cell wall. Okay, and this happens in the cutting mode, and the waveform is a continuous waveform. Okay, when we will have next lecture on electrosurgery, you will understand this better. So cutting uses continuous waveform that will lead to the heating of the cells up to 100 degrees centigrade, which will lead to the cell wall explosion and which will cause vapor release. While when we use the bipolar coagulation, that will cause that uses interrupted waveform, and the temperature will rise slowly, but it will go more than 200 degrees centigrade, and that will lead to carbonization, and it will lead to the cellular debris. Okay, so the cellular debris will be released. Here there is a cell wall explosion, while here there is a carbonization. Okay, so the cutting mode and the bipolar mode or coagulation mode, you should understand what exactly the difference is. Details we will see in the next when we will talk about electrosurgery as such. Okay, so in both processes, vaporization of the cellular material releases surgical smoke into the operative field, but it's more with the cutting mode. Okay, because there is a cell wall explosion and more of the water vapor release. Okay, so if you see the chemical composition and biological composition of this particular smoke, so almost more than 80 chemicals have been identified, such as hydrocarbons, nitriles, fatty acid, phenols, etc., and additional toxins like hydrogen cyanide, formaldehyde, benzene. These are carcinogens. Okay, and gases like carbon monoxide, methane, etc. Okay, and chemical load comparison. What they mention is if the 1 gram tissue is burned, the smoke generated is equal to the 6 cigarettes. Okay, so that much smoke actually we are inhaling. So biological composition, blood and tissue fragments, they are present in the particulate matter. Then bacteria and viruses, they are also likely to be present in this particular this smoke. Then what is the airborne potential? Particle size less than 100 micron can remain airborne, and surgical smoke fits into this category. So if the particle size is less than 100 micrometer, it will remain airborne. Okay, smaller particles disperse more widely. Now, when we use the electrosurgery, that the particle size created is the smallest, that is 0.07 micrometer. With laser, it is up to 0.31 micron, and ultrasonic scalpel, that is the largest one, that is 0.35 to 6.5 micron. So this you remember maybe from SBA point of view. So the largest is the ultrasonic scalpel in the range of 0.35 to 6.5 micron, and the smallest is with electrosurgery. Okay. Now, what is the respiratory penetration? If the particle size is less than 10 micron, it is inhalable. If the particle size is less than or equal to 5 micron, it is deposited into the nose, pharynx, trachea, and it requires mucociliary clearance. If the particle size is still smaller, less than 2.5 micron, it will reach to the alveoli. It will be phagocytized by the macrophage, and it will create or generate an inflammatory response. The bacteria and viruses, they will fall into less than 2.5 micrometer range, and that will lead to the deeper penetration and higher infective potential. Okay. Now, what are the factors which are affecting the effect of this plum? It is the concentration and impact. So if the particle concentration is more, there will be more impact. Okay. So the particle concentration influences exposure level, dispersion, and severity of respiratory tract irritation. Higher concentration will correlate with the increased toxic, inflammatory, and infective risk. So concentration of surgical smoke and impact on risk. Surgical smoke concentration varies and based on surgical technique, that is laparoscopy, will lead to less escape into the theater than the open surgery. So open surgery will have more release of this smoke into the atmosphere, while laparoscopy will not that much. Okay. So instrument type and energy levels used, operating theater volume, and ventilation systems in use. So there are various ventilation systems which are in use. So all this will affect the concentration and impact of this particular smoke. So that is surgical technique, then instrument type and energy. We have seen how this energy source will have different effect on the particle size also. Okay. Then operating theater volumes. Then tissue type influences smoke production. Highest is from organ parenchyma and fatty tissue, and lowest is from the muscle. Okay. So particle concentration rises rapidly during the surgery. So baseline particle size, if it is 60,000 particles per cubic feet, that will lead to 1 million per cubic feet within 5 minutes of electrosurgery. Okay. So smoke levels may take 20 minutes to return to the baseline after the energy device stop. Okay. So it takes at least 20 minutes for the particle size or smoke level to come back to the normal. So intermittent device use will have continuous low level exposure for the staff and high concentrations detected throughout the theater. All staff and patients are potentially exposed because of this particular concentration. Okay. So what are the clinical effects of surgical smoke? There may be respiratory and systemic symptoms. Then infective risk is there that can happen. The various staff surveys have been conducted. Various symptoms such as headache, uh, uh, then eye watering, etc., cough. These are the symptoms which can happen because of this surgical smoke. Okay. Then carcinogenic concerns are there with this surgical smoke. Chemical carcinogen like benzene is detected. Acceptable exposure should be zero. Okay. For cancer risk, no proven increase lung cancer risk. Then chimney effect, which is seen in laparoscopy, and that concern of malignant cell escape. That is a theoretical port site metastasis. Studies show no viable malignant cells capable of seeding. Okay, so there is a chimney effect with the carcinogenic concerns. Then patient specific risk like open surgery protected by the closed circuit ventilation. What happens in the open surgery? So in anesthesia machine, the CO2 gets absorbed. Okay, there is a rebreathing. And in laparoscopy, there is a trapping of the smoke and there is a high carbon monoxide and cyanide level. Absorption will cause impaired oxygenation to the patient and postoperatively pain, nausea, headache, all these symptoms will be produced. Okay. Then operative visibility. Smoke will also reduce the operative visibility and impairs the precision, prolongs the operation time, and increases the complications and recovery time. Okay. So, what are the risk reducing measures? One is a personal protective equipment. So, standard surgical mask filter, it will filter particles more than 5 micron. Okay, and that is ineffective for most of the surgical smoke. Sometimes they can ask you this as an SBA. Okay, so this standard surgical mask will filter the particle size more than 5 micron. Okay, so loose fitting mask will worsen the protection. Then you have respirators, that is N95 or FFP2 or higher. So they will filter the particle as small as 0.1 micron and still not fully protective against the viruses, and they will require a formal fit testing. Okay, then there are various ventilation system like a general theater ventilation. Okay, so general theater ventilation should provide at least 15 or more exchanges per hour and maintain positive pressure. Okay, and because of this positive pressure, outside air is not contaminating the theater air. Okay, so but this general ventilation theater is not sufficient alone and requires adjunct system. So there are various systems which we will see in the next slide. But what is more important, if whatever this adjunct system which you will use, they should be at the source, as close as to the source, because if it is at 1 centimeter from the source, it will capture 98% of the smoke. But if it is at 2 centimeter or beyond, it will capture only 50% of the smoke. Okay, so the distance of the this smoke evacuation system from the source is going to be very, very important. So there are various smoke evacuation system, like there is a wall suction and there is a smoke van, which is a handheld instrument. Okay, so it will aspirate the smoke and the rate is around 5 cubic feet per minute. Okay, it is suitable for low volume plumb. Then there are portable smoke evacuation system. There is a high flow filtration and it is around 30 to 50 cubic feet per minute. It removes particles more than 0.12 micron with 99.9% efficiency, and it reduces odor and noise. Then laparoscopic smoke filtration, that filters escaping phlegm via the trocar filters, and it is needed during smoke release and decompression. Okay, so that finishes the topic of smoke. So